Great. Hi, everyone. Thanks for joining us and welcome. Sorry for the slight delay as we were working out some technical issues on our end. We want to make sure that we're doing everything as smoothly as possible for you. Happy Pride. Last June, we're now recording. Last June, we were fortunate enough to have one of UMHS's alumni, Dr. Soren Estvold, join us to talk about LGBTQ plus medicine and theory. And it was such a success that it actually kicked off a series of other discussions that we've had over the past year on all sorts of different topics where alumni and faculty and current students have shared their insights, their thought leadership. They've offered career advice for current and prospective medical students and for other people working in healthcare. And tonight we are thrilled to be able to welcome back Dr. Estvold as he shares some new information with us about LGBTQ plus medicine and theory. So welcome, Dr. Estvold. Thanks for joining us.
Thank you. Thanks for having me.
Before we get started with your presentation, we were hoping that you could tell us a little bit about your background and also your current practice.
Yeah, so thank you, Megan, for the introduction. As you mentioned, I graduated from UMHS in 2018, landed a residency here in Georgia at Medical College of Georgia in Augusta, Georgia, doing family medicine. And then I kind of fell into this role where I was doing a lot of LGBTQ medicine and primarily transgender health. And actually currently right now, I'm in our equality clinic, which is our transgender health clinic here in Augusta, because we have equality clinic happening right next door. And so as I'm giving this to you live, we're actually seeing patients currently. So that's kind of my background. I'm family medicine. And so I love it and I can't wait to share it with you guys.
Awesome. Thanks so much. Also joining us tonight, we wanted to welcome some students from St. Kitts. So hello to everybody who's joining us in St. Kitts from campus. Welcome. We're happy to have all of you joining us both on campus in St. Kitts and virtually. We're about to get started with Dr. Estvold's presentation, but we wanted to invite you to submit questions into the chat of whatever platform you're using. We're going to monitor those questions throughout the presentation, and Dr. Estvold will occasionally stop and respond to those questions. And then following the end of his presentation, I'm going to turn this over to Nisha Shetty. She's the AMSA president of UMHS, and she's going to be moderating the live Q&A from St. Kitts. So thank you, Nisha, and welcome to all the students on St. Kitts.
Thank you. We're ready to start whenever you guys are.
Fantastic. So I am going to go ahead and open up the presentation that Dr. Estvold has put together for us. And if you can bear with me for a moment, I will share my screen and hopefully this all just goes smoothly for everybody watching. So bear with me for just a moment and we will get started. Okay, can everybody see the screen? Perfect. So I'm going to turn it over to you, Dr. Estvold.
All right, thank you so much. So like I said, this is a very interactive presentation. So if any of you students have any questions, please chat them in, yell them out. Don't be afraid to stop me. This is a fun, about an hour-long presentation that I've given out all across my medical campus here to all the different specialties. And it's really more of a boot camp of how to do LGBTQ medicine. It covers things from like the actual medicine of what I'm doing with my patients to more things like cultural competency, learning like all the background lingo, how to get more comfortable with your patients, stuff like that. So I hope you enjoy it. It's a fun presentation. And let's get started. Go ahead, next slide. So full spectrum medicine, what does this mean to you guys? And that's my hospital logo right there, in case you guys were wondering. They're very much into Pride this month and into LGBTQ medicine, which is really cool for a place in the South. But full spectrum medicine, like what does that mean to everybody? And you guys can yell out anything.
Students
so
on
to me,
Kitts?
Yeah.
Full spectrum medicine. Anybody want to say something? Yeah.
Good, I
go
see a
ahead.
hand.
Okay, let me see if this will. I just gotta switch over my mic real quick.
I would think it's treating patients of all gender and sexual orientations.
Yeah, and I like to actually reduce that. That's a very good answer. I like to reduce that down even further. It's treating any patient regardless of who they are and what their background is. And then I like to focus more on gender, sexual orientation spectrum, because it helps break down these healthcare barriers that this patient or this population faces. So next slide. So does anybody recognize this alphabet soup? And you guys can nod, raise your hand, anything. Who thinks they can name all of these letters and know what they stand for? Let's run through the audience with it. Who knows what the L stands for?
You guys can scream it out. And
Yeah, shout it. Good. How about G? I heard that.
A.
B.
Bisexual.
Excellent. T. Transgender. How about Q? This is where it starts getting a little bit more difficult.
If anybody else knows.
Queer, questioning.
Yeah, so queer and questioning, those are the two Qs. How about 2S? This is probably the most difficult and newest addition. Does anyone know what 2S means?
Two-spirit?
Yeah, Two-Spirit. And we'll get into that, but Two-Spirit is more of a Native American kind of, not version of LGBTQ, but it's a Native American version of gender theory that they've actually had around for hundreds and thousands of years. Does anybody know what the I stands for? Yeah, intersex. How about A? I think I heard asexual in there. How about the other A? That one's actually for ally. We threw that in there. And then P, do you guys know what P stands for?
Pansexual?
Yeah, pansexual. Good. And then the plus. Plus just means kind of everything else. Exactly. Very good. And this is a lot. And I don't expect you guys to know what LGBTQ2SIAAP plus stands for, nor do I expect you to use it at all. Just saying LGBTQ is fine, LGBTQ plus, that's all very inclusive. You can also use the word queer. It's a reclaimed word, and it's totally okay to use with your patients as well. Go ahead and next slide.
Okay.
So here it is again, in case you guys need a deeper dive into the definitions. I think it's important that you at least have a concept of like what pansexual means. It's a different form of attraction. I think it's important to know what transsexual versus transgender means, because each of these, like I said, it's a spectrum. So each of these gender identities are very different and individual to the person. Go ahead and next slide. So here we go. I just broke it down really easy and really short for you guys here. One thing I really hope that you guys take away from this presentation is the inclusivity that I've included. So you should be seeing a lot of imagery of not just cisgender white males, because that's what we normally have thought about for decades, that encompass most of the LGBTQ population. But I want you to take away from this that it encompasses everyone from every aspect and walk of life. Go ahead and next slide. So does anyone know who these people are? You guys should all know the one on the right, the African-American one. Does anyone shout that out?
It's Laverne Cox.
It's not Laverne Cox. She'll appear later in the presentation.
Oh, wait,
actually, it's RuPaul.
Yeah.
It is RuPaul, yes. And then the one on the right, that's Spikey Van Dyke, one of the US premier drag kings. So where do they fit into this spectrum, or where do they fit into this community? Do you guys have any ideas? Maybe. So I like to include this slide because I like to highlight that drag kings and drag queens are not necessarily transgender, although they can be. They do fit into this spectrum, the LGBTQ spectrum world, somewhere in there. But the main point of a drag queen and a drag king is they're there for entertainment value. Okay, they're not a gender identity and they're not a sexual orientation identity. Okay, so it's important to kind of tease that out, that you don't identify as a drag queen as part of the sexual spectrum. Does that make sense? And this is actually a distinction that I had to make to a lot of the older white males that I've lectured to over the past year and a half, because they just assumed that a drag queen was a transgender or transsexual female. And that's not always the case, but it can be. Go ahead and next slide. More definitions. So just so you guys know what we're talking about, and I want you guys just to be more comfortable with these definitions, okay? So transgender, so that's a person who identifies differently from the sex that they were born with, okay? And we should all pretty much know what that means by now. So if you were born female, but you identify as a transgender male, you felt that your insides, what you feel on the inside, does not match what you present on the outside. And we'll dive into that in a little bit. Gender identity, that goes with how you view yourself and how you identify with yourself, and how you express that to the world. Sexual identity is who you're attracted to. Cisgender comes from a Latin word for cis, meaning the same. So cisgender would be like a male-born person presenting as male, or a female-born person presenting as female and identifying as female. So cisgender, same gender. Whereas transgender, right, trans means the opposite. Transmasculine and transfeminine, those are kind of more newer terms that I use a lot in my practice. Transmasculine female, or oh, I messed that up. It's supposed to be trans, did I get that backwards? A transmasculine male is, oh, you're right, it's a female to male transgender person. So they're transmasculine, so they're now presenting as a male. Where transfeminine is male to female, they're now presenting as a female. And I like to use those words because to me, it's more descriptive to describe a patient as transmasculine. I know they're transgender, but they're also male presenting, or transfeminine. I know they're trans female, but they're presenting as female. So I like to use those a lot in like my notes and stuff. Go ahead and next slide. So for all of you visual learners out there, this is the genderbread person, and this is for you if those definitions just kind of went over your head. So as you can see, identity, it takes place more in the brain and how you identify with yourself. Attraction is who you're attracted to romantically or sexually. Sex is all determined by your genitals. And so that's why we can have transgender people, and it's more referring to their sex and their genitals. And then expression is how you present yourself to the world. So think about this, and this is why sexual identity is on a spectrum, is because if you intermix all four of these aspects, expression, identity, attraction, and sex, you can get a whole combination of a person that's different from the next person. And so that's why we see gender identity and sexual orientation as a spectrum and not just binary male, female, okay? And this is not a new concept. I just think that we haven't really had the words to express this. And I'll get into that in a little bit. Go ahead and next slide. Are you guys keeping up with me? Is this kind of making sense, this background? You guys can just shout it out.
Are there any questions from the audience so far that you want to jump in and ask? I know we'll do the live Q&A at the end, but just want to check in and see if there were any questions.
We're almost done with the theory part.
Okay.
Cool.
Any questions yet?
Okay, thanks.
All right. Next slide. Cool. So does anybody recognize this? This is the Kinsey scale. Has anyone heard of this? A couple of people have. Cool. So the Kinsey scale is actually an old concept. Dr. Kinsey did all of his research in like the 1940s and 50s, where he went out into the community and he gathered data from over thousands of different populations and different people. And he asked them all of the nitty gritty questions about sexual orientation, their sexual habits, their sexual lifestyle, stuff like that. And he was one of the first people to really quantify and aggregate all that data. And he kind of came up with two important theories. So his first theory that he came up with was that sexuality is a spectrum. And that's what we call the Kinsey scale, 0 to 6, where 0 is exclusively heterosexual, 6 is exclusively homosexual. And you see people identify all along the scale. The other important concept that Kinsey brought to life was a Kinsey 3, which is an exclusively bisexual person, that somebody can identify as bisexual. So neither homosexual or heterosexual, but an attraction to both. That was a very new concept. That was a very revolutionary concept. Is that my feedback?
No, that's ours.
Okay. So, but Kinsey was a very big pioneer in the world of sexual identity and sexual spectrum. And so that's why it's important to know his work and highlight his work. Go ahead and next slide. All right, so it's June, it's Pride Month. You guys should kind of recognize some of these things. We're going to talk about sexual identities. So there's over 34 sexual identities to date. As you can see from the little flags on the side, all the different sexual identities have been given a flag because we like the flags. And they all stand for something specific. I'm not going to tease out what all the 34 different meanings are, but it's important to know that there's 34 of them and they're growing every day as people identify as things like aromantic or as demi-romantic, bisexual, transgender. We're learning new words to be able to express our sexuality. I wanted to highlight the two flags over there. Does anybody know what the top flag is? Anyone want to throw out a guess? I'm going to pretend someone said it was the two-spirit flag. You can see with the feathers on there. And I like to just highlight it because oftentimes the Native American, Hawaiian, Asian Pacific Islander population doesn't get talked about at all. And so they've always had this concept of being two-spirit. They've had it for hundreds of years. It's written down in the Polynesian culture, in the Hawaiian culture, in the Native American cultures here in North America, but no one really acknowledged it. And it's not saying, it does not mean transgender, it does not mean bisexual. They actually believe that multiple spirits inhabited one body, where you were literally two spirits sharing one body, and that kind of determined your sexuality. And not everybody was two-spirit, but those two-spirit people in their community were often seen as religious leaders. They had special powers. They were more revered in their society for being two-spirit. And that's actually starting to come back to light nowadays, which is a really cool concept. And then does anybody know what the bottom flag is? Does anyone shout that out? Anybody? So the bottom flag is actually the ally flag. So we also gave you guys a flag, and that's where you see the black and white bars, and then you have the rainbow A kind of put into the middle of it. So everyone gets a flag. Go ahead and next slide. Cool. So flag history, the flag is actually really important. It first debuted in the late 1960s. The current flag that you see on, I guess it's my left, has meanings for each of the colors, that came to light in 1974 and was first debuted in San Francisco. So there's actually been a lot of thought that was put into it, and each stripe actually stands for something. And then the newer flag, that's called the progressive flag. It debuted in 2016, I believe, 2016 or 18. And that included the two minority colors of black and brown, and then the transgender colors. And so that was very cool, very novel. I've now even seen a more progressive flag that includes the yellow and purple circle for intersex that's interlaid into where like the white triangle would be. So we're trying to be as inclusive as possible. It does get a little complicated, and I completely understand that. But the whole point is to try and include people as much as possible. Go ahead and next slide. So it's June, it's Pride Month. We know this because all of our corporate sponsorship has turned rainbow colored. It's kind of a joke. I do like to highlight this, that LGBTQ issues don't just take place in the month of June, they actually take place all year round. And I see LGBTQ patients all year round as well. So it's important to celebrate Pride, right? To celebrate our milestones of where we've come from and the progress we're making. But it's also important to keep this community in mind all year round and not just during June. But during June, we'll celebrate it. So thank you. Go ahead and next slide. Another important holiday to remember is Transgender Day of Remembrance. So this isn't just like Transgender Day. This is actually a day to remember the people who have died due to violence experienced in the transgender community. This community is very prone to violence. It's very prone to homicide. And so it's important to remember those people who have had their lives taken to them or from them. And so we do that every November. Go ahead and next slide. And then this is National LGBT Elders Day. So unfortunately, when you hit like the age of 60, you're considered old in this community and you're considered forgotten. And so there's a huge population of people over the age of 60 in the LGBTQ community who just aren't really included into the community as much anymore. And there's a big push to change that. to appreciate our elders, to remember our elders. And so we gave them an actual holiday on May 16th. So it's important to celebrate that every year. Go ahead and next slide. Cool. So we're going to get a little bit more into community health here. And this is anyone who's interested in public health, anyone who's interested in family medicine, internal medicine. This is kind of where the medicine will start picking up for you. So has anybody heard of this gender minority stress framework? And you guys can raise your hand. And if you haven't heard of it, it's totally okay. So the gender minority stress framework, oops, let me change my screen real quick. It basically is this complex web of showing that an LGBTQ person experiences micro aggressions and micro stressors on a daily level, and those start to build up over time. And as they build up over time, they do things to compensate for that stress level, like smoking or drinking or, bad vices. But also they're having rises in their cortisol levels, and they're starting to have physiologic changes. And then as they experience these changes over days to years to decades, it starts to build up inside their body. And then they start getting actual health problems like heart disease, high cholesterol, dementia, lung disease from smoking, etc. And so what we've seen is that on a very small level, on the daily level, these microaggressions actually have very large outcomes or very large cumulative effects on the human body. And so that's where we as doctors come in and we can help and we can intervene. So those are things we're going to be looking at further in this PowerPoint. Go ahead and next slide. So let's talk about health disparities, okay? So Chandler had a study in 2020 where they looked at male sex workers who were Black, who were minorities. They looked at 4,000 of them over this 3-year period, and they found some really startling things. They found that almost 45% of them were HIV positive. They were more likely to be Hispanic. They were more likely to exhibit bisexual behavior. They had a reported income of less than $10,000. So they were generating money probably from sex work or from drug use or drug work, not being reported, but they weren't having traditional jobs. That was the important part there. They saw an increased rates of intimate partner violence. They saw increased rates of assault against them, polysubstance abuse, depression, and then increased rates of STIs, all within this population who identified primarily as Black or Hispanic. So the big thing that they were seeing is that in the non-white population, we had these huge health disparities. And so the Chandler study was trying to figure out why this was happening and why it's being highlighted in these populations. Go ahead and next slide. So that's what you will be seeing as a physician. So we have to look at these health populations and figure out what we can do to intervene. And that's a lot of what I do as a family medicine doc. I also have my MPH, so I do a lot of public health. And public health looks at kind of the community level of how we can make someone healthier. Family medicine looks at it then on the individual level. So this is an important slide. It says that LGBTQ people of color are more than twice as likely to avoid going to the doctor's office. That's why we have these disproportionate health disparities. So the white members of the community are seeking healthcare, have better access to healthcare. The non-white members of this community are avoiding healthcare, having poor health outcomes. And we'll see a lot of those people come through the ER, and we have to treat their problems in a very different way and non-preventatively as we would be able to do if they say came and saw me on a semi-regular basis. Go ahead and next slide. Discrimination. So that's a huge healthcare barrier that this population faces. As you can see from the Casey and the Way study that looked at about 500 patients, they saw that all of these patient populations experienced some form of discrimination when they came looking for healthcare. So over half the LGB population experienced some form of discrimination when going for healthcare, and then 70% of transgender people experience some form of discrimination when going to seek healthcare. And as a physician, that should make you panic. That should make you feel terrible that these people are actually trying to come and see you. And at some point along the way in their journey, almost everyone is getting discriminated against. And so some of those discriminations show up as slurs, microaggressions, sexual harassment, violence, bathroom harassment, all of these things that are just, and creating poor health outcomes for these patients. And it's makes it less likely for these patients to return for a second visit or to continue seeking healthcare visits. So that's something we have to work on, is how do we make our offices, our places of business more inclusive? Okay, next slide. I'm also in the military, forgot to add that. So I do have a couple slides about military medicine, which is really interesting because the military is doing their best to treat their LGBTQ population. But unfortunately, we're finding a lot of still similar things where a lot of providers don't know, or they're not comfortable treating the LGBTQ community. So they just don't give them good care. So that's got to change. If you go to the next slide, I'll highlight that a little bit more. So we're still seeing a large population in the military is men being treated, and especially men who sleep with men. That's what the MSM stands for. We are seeing a lot of transgender patients now. The cool thing about being in the Air Force is that they were really interested in how I can help them with their transgender air people population. And they send a lot of those people down to Texas to one of their big bases down there, one of their big medical center bases. But there still is no formal program of how, or standard operating procedure for how to treat transgender patients in the military. So that's something that's being worked on right now. And that's what that last bullet point is saying, is the guidelines have just not been written yet. So go ahead and next slide. So this is an important slide as well. I think they're all important, but this one's really important because the American Heart Association did a 2020 study that looked at heart disease within the LGBTQ population, and it found some really staggering things. So it found that women are more likely to have an elevated BMI. There's a larger increased cardiometabolic increased risk from being on HRT. And then there's also a larger diabetes risk and transgender population risk. There's a larger diabetes risk in the transgender population. So these kind of outcomes were not seen previously, or they didn't have the research background to back up these findings. And so now, since the AHA has released them, it kind of changes my guidelines and what I do. So now I've started screening more of my transgender patients for diabetes. Now I check lipid panels on all of my overweight women. Now I screen everyone for tobacco use, and I screen everyone for depression, because now all of these health outcomes have been validated through research. So it actually changes the way that we do our work. Go ahead and next slide. Cool. So now we're into the meat of the presentation. I'm going to kind of go through each of the spectrum one by one and march through what you guys are going to be doing as physicians to kind of help this population. Okay, so we're going to talk about women's health first. And I like to use real broad terms. Yeah. Sorry,
Dr. Estvold, before we jump into this, I'm just wondering if there are any questions from kids. Just give the audience members a chance to, you've covered a lot of really good information. Just want to make sure that we give people a chance to jump in.
For sure.
Can you guys hear me?
Yes.
Okay, we have a question up in the front.
Okay, so I have a question regarding the patients receiving HRT. Do you recommend scheduling these screening visits more for these patients? Do you see these transgender patients or other patients at risk more and more?
Yeah, so, and actually I'm going to leap into transgender treatment in like 10 slides, and I will cover that question there, okay?
Anybody else?
Yeah, but no, I like where you're thinking. So I like where you're going with that. Any other questions real quick? Any questions about the theory or the public health background?
Don't be shy.
Yeah, please don't be shy. This is your time.
Okay.
Cool.
We'll come back.
Okay. Yeah,
Let's jump in. Yeah.
Thank
So
you.
I like to call this women's health and not just like lesbian health, because really we look at the person. The person's a woman. So how are we going to treat her and screen her and give her the best care possible? Go ahead and next slide. So let's look at their social determinants of health. Okay. So queer women tend to they're less likely to seek healthcare or preventative services, but then ironically, they enter the healthcare system later on in life. So when they're in their third or fourth or fifth decade. One reason for that, or theory behind that, is a lot of your healthcare is linked to having health insurance. Okay, health insurance is linked to having a job, or it's linked to being married, or you can marry into it and marry somebody who has good health insurance. And so I don't know if you guys if that resonates with you. I know when I was a medical student, I had the UMHS healthcare, and that was it. And so I actually didn't have great healthcare until I landed this residency and was able to afford hospital health insurance. So, but that's exactly my point. I entered the healthcare system, truly entered it on my own when I was well into my 30s. And there was a gap where I was no longer on my parents' health insurance. I was in med school, and then now I was able to have my own. So what if you don't have a family, right? You don't have parents who put you on their health insurance. What if you can't hold down a job, or you don't have access to a job and you can't get health insurance through there, and you can't get married to somebody who has good health insurance, which was a really real thing up until a couple of years ago. So that's kind of a real reason why this population doesn't enter into the healthcare community, which means they don't receive any preventive services, which means all of their health comorbidities start to pile up on them. Good, go ahead, next slide. That's what I wanted to say that. Oh, actually, and then on the last slide, there was a bullet point that said they're more likely to receive inappropriate care. That's actually a very true statement. Lots of times if a lesbian woman or a woman who identifies as a lesbian comes into your office or somebody's office, they won't get a PAP, or they won't get breast exams, or they won't get screened properly. Mostly because the physician used to think that, they were at less risks for STIs, or they weren't sexually active with men, which is not true. Or, they weren't going to have a baby because they had a female partner. And so their screening habits and the actual preventive services that they were getting, or in this case, not getting, were completely inappropriate. So it's important to treat the person in front of you and treat them for what they need, okay? So let's look at their healthcare considerations. As I mentioned earlier, we have found that this population more often tends to be overweight, okay? And as we know, being overweight leads to obesity, and obesity leads to a further plethora of more problems. Being overweight tends to lead to diabetes, cardiovascular disease, COPD as you get older, hypertension as you get older, sleep apnea as your weight increases. This population was over 200% more likely to smoke tobacco. So that was staggering. That's the largest increase in tobacco in all of these sexual orientations. So we need to screen our women for tobacco usage and then counsel them appropriately on it and get them to quit. Increased rate of alcohol and substance use, increased cancer risk due to prolonged estrogen exposure over their lifetime. Really interesting concept. So most women who get pregnant at some point, they're pregnant for at least 9 months-ish, right? And then if you have another child, you're pregnant for another 9 months. And then if you have another child, you're pregnant for another 9 months. And so you're having these interrupted gaps in your estrogen that your body is receiving. And so it decreases your risk of having cancer. But these women who are not getting pregnant, or at least not getting pregnant at the rates of their heterosexual counterpart population, are at an increased risk for cancer because they have been exposed to more progesterone over their lifetime, okay? So that's something we have to screen them for. And then we also have to consider their fertility. Just because they're a woman identifying as a lesbian or they're in a lesbian relationship does not mean that they do not want to have kids. We need to figure out what they want to do, if they want to become fertile or keep their fertility, and how they want to use their fertility. You have to ask the patient that, because that's very important to them. Go ahead and next slide. So what are we going to do? This is kind of one of the takeaways I want you guys to have. We're going to do a lipid panel on all of these women, okay? We want to make sure that their cholesterol isn't too high, their triglycerides aren't out of whack, anything like that. Screen them for diabetes, screen them for hypertension, screen them for alcohol, tobacco, and substance use. Give them their pap smears, right? We're supposed to do that. And if the pap smears come out, not good, you retest them, or you give them a colposcopy. Do their mammograms on their regularly scheduled mammogram routine. Offer them birth control. Just because a woman is queer identifying does not mean she is not having sex with a man at some point, okay? It's very important to tease out sexual history and what is going on, so that we can help screen her and protect her from sexually transmitted infections, etc. And then mental health screening, because everyone in the LGBTQ population statistically is at an increased risk for depression and suicide. So we have to do a PHQ-9 on everyone. Go ahead and next slide. Good. So that was women's health in a nutshell. Let's skip on to men's health. And like I said, men's health, not just gay men, because not everyone identifies as a gay man. MSM, men who have sex with men, a queer man, men in general is who we're going to focus on. Next slide. So they're social determinants of health, okay? Things that make them sick, or things that increase them, cause them to have increased healthcare costs. So they're, again, less likely to have access to healthcare. We went through that. This population is affected by this twin effect of racism and homophobia inside the LGBTQ community as well. So that means like being Black and gay, you're receiving racism from that, and then homophobia at the same time. So it's like not just homophobia, but now you have more things that will lead to poor determinants of health. And that's kind of a throwback to that gender minority stress theory, that big web kind of picture we talked about earlier. Blacks are more disproportionately affected than the white population. We can think about this if you guys kind of like close your eyes and think back to the HIV epidemic of the 80s and 90s, and then all of the propaganda that came out of that, who was on all the brochures and who was on all of the ads and who was, at all the pride parades. Mostly you saw cisgender white males who were on all of the propaganda, and that's who all of the health medicines and prevention was marketed to, was only the white population. And it wasn't until within the last 5 and 10 years that it was actually started to be marketed to everyone. And we can see that nowadays. You can see the Biktarvy commercials for the new HIV drugs. It's very diverse. I think there's a transgender person on there, there's a Black person on there, there's a Latino person on there, there's a white person on there. So the marketing has gotten better, but we're still seeing the effects of the poor marketing from decades ago. Also, I kind of touched on resources were allocated disproportionately to the different races. So like I mentioned earlier, all of the white people got the proportion of the funding, whereas the Black and other races did not. This population is most likely to be single, which means they're more likely to age alone and not have someone take care of them in their later years. And we'll talk about that when we talk about the elderly population. This population is more likely to be estranged from their family. Read estranged as kicked out. We all know that to be true. I'm sure you know at least one person who's been kicked out there from their family, okay? Which means you don't have that social support system, you don't have that fallback network, and so that leads to poor health outcomes. But this population is really good about creating their own chosen family. So like a group of close-knit friends and people who support them and love them for who they are and who are not biologically related to them. Next slide. So health considerations, what is the research showing? This population is only 50% more likely to smoke. So we still have to screen them for tobacco. Much more likely to abuse alcohol and other substances. Huge risk for depression, large risk for suicide, especially in the youth population here. And that's anyone 14 to, I think, 18 or 19 years old. So we need to really screen that population. Largest risk for STIs is in this population. Largest risk for anal cancer due to sexual intercourse in this population. Much higher incidence of HIV. Despite education that's going on, the HIV incidence is still rising. It's not as dramatic as it was in the 80s or 90s, but we're still having large amounts of new population cases. And weirdly enough, we're seeing them the greatest increase in the younger population, in that kind of 16, 18, 20 demographic range. So even though the education's out there, the education is not being received well. And then this population also has a greater increased risk for eating disorders and body dysmorphia. And that has a lot to do with marketing campaigns. Go ahead and next slide. So what are we going to do? Do you guys know what PrEP is? If you guys know what PrEP, raise your hand. Good. Good. A couple of people. Excellent. You would be surprised at how many people do not know what PrEP is, especially in the medical field. So PrEP is pre-exposure prophylaxis. It's a once daily pill that you can take to help prevent HIV transmission. Okay, it does not prevent against STIs. Very easy to prescribe, very safe and effective. There's two main PrEPs out there. There's Truvada that's been around for over 10 years and Descovy that's been around for less than 10 years. Almost virtually the same drug, minor side effects from both. This population greatly benefits from being on PrEP. So when you get to be a prescriber, super important that as soon as you meet somebody who is interested in getting on PrEP or who would be a good PrEP candidate, to get them on as soon as possible. I like to tie in the two kind of social dating apps up at the top there, also the hookup apps, they've actually been instrumental in getting people on PrEP and getting STI prevention done in this population, because it can all be done through a handheld app, which is really cool. So the rest of this population, as you can see that Tao and Schwartz, those two research groups, found that we need to screen them for tobacco use, alcohol abuse, screen them for STIs, like we talked about, hepatitis C particularly, but all of the hepatitises, screen them for HPV, vaccinate for HPV, get them on PrEP. These are all kind of all basic things that I go through when I have an MSM identifying person who comes to see me in clinic. Go ahead and next slide. Bisexual health. This is the most forgotten about group on the sexual identity spectrum. Ironically, it is the largest group in the LGBTQ population, with millions of people in it. Over 15 million people identify as bisexual, and it's increasing more and more every day. So we can see in the youth population right now, in the millennial population, more and more people are identifying as bisexual. It is thought that there are more bisexuals out there, but people just didn't have a word for it. And so now that bisexuals are kind of having their moment in the spotlight right now, it's important to highlight their health. Next slide. So what do we do for them? This population is at a huge increased risk for depression. So whenever I have anyone who identifies as bisexual, I automatically give them a PHQ-9, and that's our 9-question depression screener. Absolutely make sure that they get it, and make sure that I check up on them regularly for it. Other than that, I'm going to screen them for normal age-related things I need to screen them for. So like diabetes, thyroid disease, et cetera, get basic labs on them. But it's important to really dive into your patients and ask them, you know, what their sexual preferences are, who their partners are, what kind of sex is happening, and other lifestyle choices that they have. I shouldn't say lifestyle choices, other lifestyle habits that they have, so that you can give them the best prevention and screening that they need. Go ahead and next slide. Cool. So does anybody know who these people are? And you guys can shout it out because somebody identified her last time. Yes, Laverne Cox. So Laverne Cox, who became famous from Orange is the New Black, is probably the most famous transgender woman on the planet right now. And so I put her on here because I think that's a really good example of someone who has transitioned very well. Also helps that she's a celebrity and has the money to back up her transition. The guy on the right is a UK model named Ashley Laith. Also a very great example of a fully transitioned transgender male. I want to highlight these two because not everyone looks like this. Your transgender patients will encompass an entire spectrum on their transition journey and look anywhere from completely transitioned to completely not transitioned at all. And so that's a big part of what I do, especially here at a quality clinic. Go ahead and next slide. So this is the #1 thing that people get tripped up with when dealing with transgender patients is they don't know how to use pronouns. They forget all about their grammar lessons in middle school. And then they just get so freaked out that they don't give good care at all. So I like to just briefly go over it. Pronouns are just how people identify according to their gender. So like the classics one are she, her. A lot of even our badges at work now are starting to say like he, him on them. So that's, you can choose how you identify. Now the gender neutral ones, which are important to learn how to say, are like they, them, theirs. And then you see all the ones underneath it, like the Z, here, the HIR, the ZIR, ZIR. I don't think anyone ever uses those, but they're just other options to use for gender neutral pronouns. When in doubt, I always just use they, them pronouns when referring to a patient. No one's going to get mad at you. Because it's the South, you can also say y'all. It's also gender neutral, but that's also kind of a joke. So I appreciate a laugh. All right, next slide. So transgender population. Actually, does anybody recognize this woman? There's a whole movie done about her that starred Eddie Redmayne. I don't remember her name off the top of my head. I think it's Christine something. She was a Danish woman, the first successful transgender operative patient. And the movie was called The Danish Woman. And so she transitioned, I think in the 40s or 50s, and transitioned very well and became very famous for it. But she was one of the very first pioneers of transgender operation theory. So this population, as I kind of mentioned before, very, very likely to be a victim of violence and a victim of murder, unfortunately. 2 of my patients here in Augusta were murdered in the last 2 years. It happens. It's something we need to protect our patients from. Especially if they're a person of color, read African American or Hispanic, they're much more likely to be a victim of assault or homicide. This population, statistically, due to its population size and how do I want to say it? There tends to be a lot more sex work in this population. They're at a much more increased risk for HIV. So it's important to screen everyone. And actually, one thing that I do here at Equality Clinic is I screen all of my patients every single year for HIV, regardless if they're in a monogamous relationship, sexually active or not, because I want to break down that testing stigma in this population so that when they're out in the real world and they don't get to see me as their provider, they're not going to be afraid to know their status and get their status checked, okay? This patient population is very unlikely to have health insurance. As a transgender patient, it's very hard for them to find a job and feel safe at their job. So it's very hard for them to earn money. So it's very hard for them to have proper health insurance. And if you don't have any of those, you can't go see a doctor. So that's why this clinic here is actually a free clinic. And then if any of my patients actually get insurance, I scoop them up and I take them over to AU and actually see them in my day job. This patient or this population faces extreme social isolation. They don't go out much. Or when they do go out, they're more likely to be victims of assault, harassment, those microaggressions, those micro stresses. So those are all things that we have to keep in mind. And then of course, the extreme depression. I have to screen all of these patients with a PHQ-9. Okay, next slide. And I'm sorry, I'm kind of picking up the pace because I don't want to put you guys too far over time. This is just saying that the LGBTQ population is at a huge risk for depression and suicide. And I keep saying that, but huge risk is not an actual number. They're 48% likely to experience depression, okay, in the last 12 months compared to 4% of the heterosexual counterpart population. So I'll repeat that again so you get the gravity of it. 48% of this population versus 4% of the other comparative population, okay? So if you've never been depressed, you have no idea what I'm talking about. If you know an LGBTQ person, more than likely that they've been depressed at some point. So check in on that, okay? Next slide.
Dr. Estvold, real quick, wanted to go back
Yeah.
to a question that came into the chat regarding the slide on pronouns. And there was a question about the proper pronunciation of XE.
So I think it's Z or she.
Okay.
Or like she, well, no, sorry. I have a Chinese professor and her name is XE and it's she. I don't really know. That one's not really used, but it's like,
is it fair to say that you could always ask the person the preferred pronunciation?
100%. And that's actually how I break the ice into that conversation is just what pronouns do you prefer? And that's what I ask every single population or patient. And they're usually very open and they know that you're trying to make an effort. So it kind of makes them happier. So
perfect. Okay,
yeah.
thank you.
Yeah. All right. So anybody know this woman? So the larger picture is actually Miss Spain 2008, the first female transgender pageant winner, Miss Universe pageant winner. So she represented Spain, which has never been done before. And then actually the smaller picture is Miss Nevada from this year. I believe she's 2022 transgender female, the first ever in the American pageants. So it's historic. And I've actually met her. She's a very nice person. So what do we do from the medical side? Okay, so as a physician, how are you going to treat these patients? You're still going to screen any biologic sex organ that is there. Okay, so if there's a cervix that is still present in your transgender male and they're of the right age, you still need to screen them for pap smears. And that's actually like the #1 battle that I have with my transmasculine patients is actually getting them to come in for their pap smears. But you do it. If there's still breast tissue, you still have to do a mammogram or you still have to do breast screening, stuff like that. You still have to do all of your basic labs, okay? Still have to screen them for depression. And it's also important to dive deeper and ask about sex trade, intimate partner violence, gender dysphoria, stuff like that. I always ask them if they feel safe at home and safe within their community. That's important as well. Also ask these patients about PrEP. Like I said, HIV is rampant in this population. Makes them excellent PrEP candidates. So if we can get them on PrEP, go for it. Okay, you could be saving a life. Next slide. Yeah, so transgender medicine in particular, this is the hormone replacement therapy. So this is like the bread and butter of what I do, especially here at a quality clinic. And this is actually what has made me kind of a pillar in this community here in Georgia, is because not a lot of people do HRT therapy. And it's actually surprisingly very easy. I think people are just intimidated by it. So for a transmasculine patient, someone going from female to male, all we're doing is giving them testosterone. And they're injecting it about every 2 weeks. And then we're following their labs to make sure their testosterone levels are rising appropriately and their estrogen levels are decreasing appropriately. I'm also doing pap smears on this population as well. But like I said, transitioning is like going through a second puberty. It takes about 3 to 4 years to transition someone safely. Okay. So that's why I see these patients every 3 months in their first year, and then about every 6 months after that. Usually by year 2 of going through a transition is when we start thinking about surgery. A lot of patients go through top surgery with either breast reduction or breast augmentation. We don't really do bottom surgeries just because there's very few surgeons in the US who do the gender reassignment surgeries. That's always like the big hot topic. Those surgeries are imperfect. They don't have great outcomes. They don't look great yet. So I don't do a lot of advocating for bottom surgery. I do have transmasculine patients who sometimes do want a hysterectomy, because they have so much gender dysphoria related to their female sex organs that they just want them removed. And so sometimes that's an actual conversation that we have. And if we can do it safely and it won't impact their life too detrimentally, it's a conversation that we're completely open to. On the flip side, my trans feminine patients, so that's converting somebody from male to female. Again, all we're doing is just giving them estrogen. It's actually oral estrogen. It's very safe, easy, effective, and cheap. We start them at 2 milligrams for their first year, and then we slowly bring them up throughout them as we can watch their estrogen levels rise appropriately and watch their testosterone bottom out. We can also throw on spironolactone. You guys should know what Spiro is if you've gone through pharm. Spiro is usually a diuretic, but if you give it to them at large enough doses, it can actually inhibit some of their testosterone and help suppress their some of their natural testosterone levels. But it's important that these patients are not smoking, okay? Kind of like being on oral contraceptive pills, right? The nicotine in the tobacco combines with the estrogen to help form blood clots in your body. Those blood clots can then go to your brain, your lung, or your heart, and then can kill you. So that's actually a very real conversation that I have with my patients is no smoking. If you're already smoking, I will not start you on estrogen therapy. And then if you pick up smoking, I will actually stop your estrogen therapy. But oftentimes, if you talk to a patient and say, what is more important, your tobacco, your cigarettes, or transitioning to the person you've always wanted to become, make that choice. And often they'll kick the tobacco, but it can be hard. All right, next slide.
Dr. Estvold, we had one other question in the chat related to pap smears for transgender patients. And the question is, do you have any specific recommendations to help our trans patients with the cervix feel more comfortable when they get their pap smears?
Yeah, so it's going to be a very uncomfortable conversation, but you have to do it. So the first thing I always do is I ask the patient, do they know why they're getting a pap smear? So I'm not just being like, you need a pap smear, you need a pap smear. They actually need to know why we're not doing or why we are doing it. And that's to prevent cervical cancer. And so I, tell them that cervical cancer is completely preventable, it's completely treatable, but if left unchecked, it's completely deadly as well. So that's why we need to do the pap at least every 3 years. Okay. And so it's terrifying to me when I get a 27-year-old or 30-year-old patient who's never had their pap smear checked or who's never had their cervix checked. So then that's the first barrier that we break down. And then I usually give them 3 options. I say that they can come and see me and I can do it, right? Family medicine, we can do pap smears. I can set them up with a great friendly OBGYN, and they can do it, someone within the community. Or here at a quality clinic, we actually teach them how to do self-paps, which is really neat, where we have, I think like the stylet, and we teach them how to go down and actually collect their own sample and get it into, the cervical os and twirl it around and get a good cell collection and put it back in the bin. And then we collect it and send it off to LabCorp. And that has a pretty good success rate of them actually collecting enough cells to run a good pap off of. And so I'll give them 6 months to figure out which option they want. If they want to learn how to do their own self-pap, and we'll do it here at a quality clinic, and then they don't have to worry about it, or I'll bring them into my office and I'll do it. Or, because I have a really great rapport with a lot of my patients, and sometimes that's their most comfortable option. Or if they have an OBGYN that they've seen before, they can go do it there. But I make it absolutely imperative, and I set a deadline. Like, we have 6 months for you to figure it out. We have 6 months to get it down, because we cannot let your cervix go unchecked. Okay. So that's how I do it. All right, I'm going to clip right along because I don't want to keep you guys too long, but, and I hate to do it because this is the elderly population that doesn't get talked about, ironically. So the elderly population is over the age of 65, but it is important to talk about them because they're a large population. It's over 1 million LGBTQ adults. They're more likely to be single, which means no one's caring for them. Less likely to have kids, which also means no one's caring for them as they age. They're more likely to live in poverty. So 1/3 of them live in poverty, and then they're alone in poverty, and then they're less likely to talk to their healthcare providers about their sexual orientation. And you wouldn't believe how many people over the age of 65, I've actually asked them sexual orientation questions. And I've gotten several people to come out to me, and they said no one in their entire lifetime has ever asked them these questions, and they're 70, and they would finally like to be able to talk to somebody about it. So it's important that when you're doing a history intake and everything, that you're asking the hard questions, and this is one of the hard questions. Next slide. This population is still sexually active. So that's what the Lindau study found, that the 65 to 75 age range found that half those people were sexually active. And then the 76 to 85-year-olds, like, read that again, 76 to 85-year-olds were still, 25% of them were still sexually active, which means you still need to do STI education. You still need to give out condoms. You still need to educate them about, HIV and how to protect themselves, stuff like that, because it's still a very real thing. So dive into those. And that's the top statistic. 92% of them do not use condoms because they think, well, they're already over the age. What's the worst that could happen to them? So really, condom education in your 70-year-old, it's a lot of fun, but you have to have that conversation. Next slide. The cool thing is that this population tends to be dying of normal things. So cardiovascular disease, depression, or not sometimes depression, but dementia is what I meant to say. They're still getting like long-term normal things like cancer versus dying of HIV anymore. So it's important to still screen, still screen them for things like cancer, cardiovascular disease, diabetes, still treat them for all those normal things, and then also screen their mental health and depression. Next slide, please. So what are we doing here at AU? So I've been here, I'll be a PGY3 in a week. So I've been here for the last 2 years. These are kind of things that I've been doing to help kind of make this hospital system more LGBTQ friendly. These are all things that you guys can be doing and bringing with you as well. Next slide. Cool. So I made a poster that talks about all like the medical screening and stuff, and how to interact with these populations. And this poster was sent out to all the major departments throughout the hospital and put up. And actually, I think UMHS has a copy of this. So if you guys want this, it's a cool printout. You can give it away to people. It makes you look really knowledgeable and culturally competent. Okay, next slide. The badges. So I actually invented a badge with the flag on it and the transgender flag on the other side. And it kind of condenses everything in that poster and everything I've been talking about. So it breaks it down by subpopulation and what to screen them for and what labs to order. Basically, I wanted my colleagues to have it because if they had an LGBTQ person and they just panicked in the room and didn't know what to do for this person, they could say, oh, I have a bisexual in front of me. I should do labs. Here they are to order them. I should screen them for depression. Cool. You just provided excellent care. It also has how to prescribe PrEP on here. So you literally just have to walk through it. And then if you're like, oh, one of Dr. Estvold's transgender patients is seeing me because he's out of the office today, I should screen them for this and I should order these labs and check their testosterone. It's all written down there. But the other cool thing is that the badge was designed to kind of stick out from your other badges so that a person will actually see the rainbow flag on it. And you wouldn't believe how many times, like in the ER, I've had a patient say, oh, I like your badge. And then they're kind of like letting you know that they know that you're a safe person to talk to. And then now they can kind of talk to you more in depth about their healthcare and their needs and what they're concerned about. And you've created a safe space for them. And so it's been instrumental. I think about half of the hospital here is wearing them, which is really great. Next slide. Quality clinic. This is where I'm currently at as we speak. It's mostly an HRT clinic. About 98% of what we do here is the actual transition therapy every second and fourth Wednesday. It's an after hours clinic, which is kind of cool. It's a free clinic. Patients travel up to 5 hours to come and see me to do their HRT. I have a couple telehealth patients that I see every single visit who will telehealth in from like Florida or South Carolina or something. But mostly we do HRT here. Every once in a while, we'll come in and have like a true family medicine primary care visit where they just haven't seen anyone and they have something going on with them, or their blood pressure is insane and I need to do something about it. So it's a lot of fun. Next slide. And if you guys rotate through Augusta, I don't know if you guys are still doing that, but that's actually where I first landed when I was still a med student, was in Augusta. You guys can totally come work with me here, and it's a very fun experience. Here's other resources for you guys. Like GLAMA has a good directory of physicians per zip code. So you just type in like the zip code and it'll bring up the nearest physician. So wherever you are on your rotations, if somebody needs help finding a provider, you can use that as well. So highly recommend it. Next slide. So what can you do? Wear something with a rainbow on it. That's kind of the biggest thing. So like I have a little rainbow pin here. Like I have a little transgender Mickey here. Those actually make patients feel so comfortable and seen and cared for, and know that you will be compassionate towards them. And that way you can provide better care. And it's so instrumental. And just throwing up like a rainbow flag, like on your laptop or, you know, sticker, or like in your office, or having like on your stethoscope, it's so, so helpful. And you would be amazed at how much more of a difference you will make in that patient's life when you just did like something little like that. Go ahead and next slide. That's kind of the same thing as what I was saying. Go over your clinic, make sure you have real gender neutral intake questions. Make sure your staff is fully updated. I actually had to sit down and have like a little boot camp with my family medicine staff for all like the front desk intake people, so that they would know I have transgender patients coming in, and one, I will not accept any sort of discrimination towards them, but two, how you can provide better service and care for them. And it's gone over wonderfully here. So make anyone who's patient facing inclusive, and help kind of train them up and just give them a little bit of training. It'll be super helpful. Next slide. Oh, good. We're at the end. These are all my references, so you guys know that I know what I'm talking about. Go ahead and advance. And then there's an ending slide you can end on. So that was it. I went 6 minutes over. That was like my LGBTQ medicine boot camp for you guys. I know for a fact that you guys only get like 1 or 2 hours of actual LGBTQ medicine training, but it's a real need in this community, and it's a real need in healthcare right now. So if you guys have any questions, like this is your time to ask it, and I'm here for you. But thank you for listening to me.
So Dr. Estvold, before I turn it over to Nisha on campus at St. Kitts, I just wanted to thank you again for doing the presentation. And I just wanted to remind everybody who's tuning in that we are recording this live stream, and we will be posting it to our YouTube page with all of our live stream events. So if you want to go back and reference anything that Dr. Estvold talked about in the presentation, I know he covered a lot of material, so if you want to go back and refer to anything, this presentation will be posted to the UMHS YouTube page. So just wanted to make that point. And at this point, I'm going to go ahead and turn it over to Nisha on St. Kitts and see if we have any questions from the audience for Dr. Estvold.
Can you hear us?
Yep.
Okay. Hi. So I actually have 2 questions regarding the labs. How often do you order the labs for trans feminine patients who are taking spironolactone to monitor their potassium levels?
So normally just every 3 months. Their potassium levels don't go crazy or anything. I might monitor it more frequently if they're on another diuretic like HCTZ or something, but normally just every 3 months is fine.
Okay. And then do you regularly screen for DVT and pulmonary embolism while they're on estrogen, or no? Okay. All right.
No, it's usually not needed, but I counsel about it when I get them started on estrogen.
Okay, so my question is, when treating a transgender patient and they request hormone therapy, there happens to be like some kind of contraindications in giving hormone therapy to this patient. How do you go about the process of explaining this to the patient, especially if the patient refuses to acknowledge the medical advice we give?
Yeah, it's a great question. Because that does happen. There's a small handful of patients that I actually don't start. Everyone gets an initial consultation with me, and then we'll start hormones after their lab work comes back. So if there is something, especially most of the time it's the smoking issue, if they're smoking, if I just explain it to them, like why we can't do it, like the smoking will cause a clot that can go to your brain and you can die. Most of them really understand it when you put it that way. You don't really sugarcoat it. And I just kind of frame it that way, like how important is this transition to you? And my goal is to get you as healthy as possible through this whole transition period. And then if that doesn't work, usually kind of the last thing you have to say is like, well, this is my license. And if you die on my medical license, this looks bad on me. And I'm not going to take that risk. So you can either do what I say and how we're going to do it, because as the physician, you're the one running the ship. And if they don't like that, they can go find their hormones somewhere else. Unfortunately, a lot of people go online and buy black market hormones. But most of the time, we don't have to go down that road.
We have another question.
Fire away.
Yes, you mentioned that us medical students, we do like 2 weeks LGBTQ medicine, but how do you extend that? Like in terms of how do you get more into the actual like field?
Yeah, so actually, I'm glad that you asked that, because I kind of stumbled into this field. So there was about a 2-year gap period from when I graduated UMHS until I actually landed a residency. And that's because I flubbed step 2 and I did not pass it on the first round, which means I couldn't then go through the match process my first year, and I didn't match the first year. So I knew, and when I didn't match, that was super heartbreaking, but it also meant that like I need to figure out what can I do to make myself more competitive than everyone else. Obviously, I need to volunteer and do something so that I can, when I interview over the next year, I can be like, look, I volunteered for this year. This is what made me special. And fortunately, there happened to be a quality clinic here in Augusta because I was living here. I got a job here during that next match cycle. And so I got the job at a quality clinic. I'm working and volunteering with them. And that's how I kind of stumbled into LGBTQ medicine and HRT as well. But where I'm kind of going with this for you is that if you are interested, you have to just start reading about it, try and volunteering for it, try and find like different like LGBTQ health centers or clinics that you can volunteer at, and then just read everywhere. There's actually a really great article that ACOG put out in March of 2021, so a year ago. And ACOG, right, is the OBGYN college, American College of OBGYNs. And they took it upon themselves to amalgamate all of the information and research about transgender healthcare and created a 14-page article about it on how to do the therapy, how to make your office better, what to do if your transgender patient becomes pregnant. Can your transgender patient be on birth control? All of those things, they amalgamated into one 14-page paper, and then they shipped it out to all of the OBGYNs. And it's actually the most comprehensive guide to transgender medicine that's out there right now. And it's easy to read. So, I mean, just doing stuff like that. I have a, like Google News alert set on my phone for anything related to transgender medicine. I'll get an automatic email sent to me when a new article comes out, and then one for LGBTQ medicine. So like, I know you've heard it a million times, but like, you just have to kind of keep learning, keep really interested in things that make you happy and what things that you're interested in. That's the long answer. Anyone else?
I think we have some online as well.
Yeah.
So Dr. Estvold, I know you anticipated or just answered one of the questions that other people were asking online about the practice of LGBTQ medicine, and just sort of an extension on that. Let's see. Oh, here's one more. Did you receive a lot of pushback when you were trying to implement inclusivity in your program at the hospital, like in terms of using the rainbow tags, et cetera?
Yes and no. So, and I'm glad you guys asked that. So I'm in Augusta, Georgia, which is the South, right? It's not Atlanta, so it's not metropolitan South. It's like actual rural South Georgia. I don't know how many of you guys are going to end up here, but it's not a very inclusive place at all. And a lot of the healthcare providers tend to be like older white males with very Southern, deep religious conservative backgrounds. So that was kind of a big initial pushback. But luckily at my program in family medicine, one, they were very supportive. So when I actually went through the interview process, that's kind of what I told them, like, as an LGBTQ person, this is what I can bring to your program. And this is a whole patient population that no one's really serving and making feel special. And I can do that. So they're, one, really receptive to that. And then two, I think because LGBTQ medicine is so novel right now, I mean, there's only like 3 fellowships or 4 fellowships in the US right now who do it. And not a lot of universities really push it unless you're in like a big urban center, you know, in like Seattle, New York, Chicago, Miami, something like that. So the fact that they had somebody who wanted to champion LGBTQ medicine for them and do all the dirty work and do all the hard work, no one told me no. So like when I made the badges, they said, okay, like we'll print them. You can pass them out to people. And I did, and I passed them out like candy to everyone. And a lot of like the residents love them because we have a lot of residency programs here at MCG. And then it just caught on. And a lot of the a lot of the more experienced physicians were just excited that somebody was actually doing this work and that somebody was actually kind of serving it to them on a platter. So yes and no, like no one was outright like, this is not good, we can't do this here. No one ever said that to me. But I think one of like the cool parts, one of the best things about it was I remember being on an elevator and I saw one of the rainbow badges on another physician, and I was like, oh, cool, nice badge, because I wanted to see what they did. And the woman actually stopped and she read it to me and explained exactly how it worked back to me. And she had no idea that I actually made the badge, and I didn't tell her. But she understood it and she was very proud of it. So I think if you're just willing to kind of put yourself out there and do it, people will be really receptive to it. And kind of closer to home, I don't know if you guys know this, but we actually had an LGBTQ club on St. Kitts at the med school that I started. Again, because nobody told me no. They said, if you're willing to put in the hard work and the time, like go for it. And so that was, you know, if you're willing to do it, a lot of people will just let you kind of do what you want if you're willing to champion it. So thanks for asking that question.
Thank you. So Nisha, did you want to ask the question that was just posted to the chat?
Sure, I can ask that. We had somebody send in a question who couldn't be here, but he said, what are the acceptable ways to ask patients about their gender identity in electronic health records?
Oh, that's hard. Mostly because a lot of electronic health records aren't equipped to accurately record the person's gender identity. And that's very true. Like even at my university here, almost all of my transgender patients are misgendered in the electronic health record. So it's important for me that when they come in, I just ask them, like, you know, I have like a whole template when I'm doing my workup note with them, like what name do you prefer? What pronouns do you prefer? What do you prefer I call you? Those are all real basic questions I ask. And then I actually put those in like size 27 font inside their actual note. And then like in some of the systems, you can have like an actual sticky note, like in their chart electronically. And I will put like their name and their pronouns in huge font all over that. So you just kind of make it as easy as possible. So that way, when a physician's going through my notes, if they happen to see this patient elsewhere and they pull up my note, it says like front and center, you know, goes by Crystal, prefers she, her pronouns. You have to spoon feed some people for it, and that makes it easier.
Right.
I hope that answered the question.
Oh, I think it did. We have another question. Can gay couples access healthcare through their partners?
Yes. So my husband has excellent healthcare. They can now, and that was not always true because, right, gay marriage didn't get passed until like 2000. Well, I was on the island, so it was like 2015. But yeah, long story short is you can. And so like I signed my husband up for health insurance when I signed up for health insurance. So, but if I didn't have access to it, he wouldn't have had access to it. And then we're back in the same pickle all over again.
Right. Okay. Yeah. Any other questions, guys? No, I think that's all of our questions.
Great.
Yeah.
Well, thank you to everybody who joined in. Thank you to everybody who joined us virtually. Thank you to all the students on St. Kitts who stayed late and are taking a late bus
Mhm.
back. We appreciate you being there and appreciate all of your thoughtful questions. Thank you, Nisha, for getting that organized. And thank you, Dr. Estvold, once again, for sharing your expertise with us. Your information is so valuable, and we just really appreciate you taking time out of your incredibly busy schedule. So thank you so much. We appreciate it.
Of course. Thanks, guys. And hang in there. I was once in your seat not too long ago. So dreams do come true.
Awesome. All right. Thank you so much, everyone. Have a good night. And once again, the recording of this will be posted on the UMHS YouTube page